Hello, I'm Dr. Nirupama Kasturi, and my lecture is on sixth cranial nerve palsy and related brainstem syndromes. The sixth cranial nerve supplies the lateral rectus muscle in the eye, and when there is a palsy of the sixth nerve, it results in esotropia of the eye in primary position due to unopposed action of the medial rectus and also marked limitation of abduction in the affected eye due to the lateral rectus weakness, as you can see in this picture. Although in some cases, the sixth nerve palsy may be a benign condition and it may be self-remitting, but sometimes it may be due to a severe neurological process like a brain tumor or raised intracranial tension, and it has to be identified and treated as an emergency. So, in this lecture, you will understand the anatomy and course of the sixth cranial nerve, and you will be able to identify the sixth cranial nerve palsy and localize the level of the lesion, and also understand the differential diagnosis or mimickers of sixth nerve palsy and know the relevant workup. So, the anatomy of the sixth cranial nerve starts at the nucleus, which is at the level of the mid pons, as you can see in this picture of the brain stem, which is divided into the midbrain, pons, and medulla. The sixth nerve nucleus lies at the mid level of pons, and it lies ventral to the floor of the fourth ventricle, and the fasciculus of the seventh nerve, it curves around the sixth nerve and produces an elevation known as the facial colliculus. The motor neurons for the lateral rectus emerge from the sixth nerve nucleus, and this constitutes around 60%, and the remaining 40% actually traverses via the medial longitudinal fasciculus to the opposite third nerve nucleus. So, this helps in initiating a conjugate gaze towards one side by simultaneous contraction of the lateral rectus and the contralateral medial rectus. The parapontine reticular formation also sends impulses to the sixth nerve nucleus, and this helps to initiate the horizontal gaze and also in saccadic eye movements, which are the fast ocular movements. The nuclear sixth nerve palsy is characterized by sixth nerve palsy along with ipsilateral horizontal gaze palsy due to the involvement of parapontine reticular formation, as well as an element seventh nerve palsy or a facial nerve palsy because of the adjacent facial nucleus, which is present close to the sixth nerve nucleus. When there is an isolated medial longitudinal fasciculus lesion, the patient develops an internuclear ophthalmoplegia. As you can see in this picture, where there is a left internuclear ophthalmoplegia, there is normal movement when the patient looks towards the left side, but on gaze movement towards the right side, there is loss of adduction on the affected side and an ataxic nystagmus of the abducting eye. And a bilateral medial longitudinal fasciculus lesion is also known as Webino or wall-eyed bilateral internuclear ophthalmoplegia. This is termed so because the patient has a bilateral exotropia in primary gaze, which is also known as walled eye appearance. And you can see here in the right gaze, the patient is not able to adduct the left eye, and there is a nystagmus of the right eye, and in the left gaze the patient is not able to adduct the right eye, and there is a nystagmus of the left eye indicating a bilateral internuclear ophthalmoplegia. When there is a combined lesion of the medial longitudinal fasciculus and parapontine reticular formation, the condition is known as 1.5 syndrome, where there is internuclear ophthalmoplegia in the other direction and conjugate horizontal gaze palsy in the direction of the lesion. For example, you can see here in this picture, there is a left 1.5 syndrome where the left eye does not adduct in the right gaze and it does not abduct in the left gaze. And in the left gaze, there is also limitation of adduction of the right eye. So since one whole eye, there is limitation of adduction and abduction, and in the contralateral eye, there is limitation of adduction. It is known as 1.5 syndrome. When there is a lesion involving all medial longitudinal fasciculars, parapontine reticular formation, and the seventh nerve lesion, we get a condition known as 8.5 syndrome. As you can see in this picture, the MLF, PPRF, and the seventh nerve nucleus are in close proximity with the sixth nerve nucleus. So the patient develops internuclear ophthalmoplegia, horizontal gaze palsy, as well as facial nerve palsy. So this can occur in central neurological diseases like demyelination or ischemia following any brainstem infarct. And because you have a 1.5 syndrome combined with seventh nerve palsy, it is known as the 8.5 syndrome. After the nucleus, we come to the fasciculus of the sixth nerve, which is that portion of the sixth nerve between the nucleus and the emergence of the nerve from the pons. So this intrapontine segment is known as the fasciculus of the sixth nerve, and it passes through the medial lemniscus as well as the pyramidal tract. You can see here, which is depicted in red, and then it tends to emerge out from the pons. So involvement of the fasciculus of the sixth nerve gives rise to certain crossed syndromes where the patient will have sixth nerve palsy along with hemiplegia on the opposite side, which is known as Raymond syndrome. And the involvement of sixth nerve, seventh nerve, as well as hemiplegia is known as Milliard-Gubler syndrome. And the involvement of 5, 6, 7th nerve, parapontine reticular formation, and the spinal tract of the fifth nerve and sympathetic fibers giving rise to Horner syndrome is known as the Foveal syndrome. After emerging out from the pons, the sixth nerve lies in the subarachnoid region, and this part is known as the basilar part of the sixth nerve. Here it courses nearly vertically along the clivus and rises to the petrous crest, where it bends forward and passes under the petroclinoid ligament, as you can see here, and it lies within this segment in the Dorellos canal. Here actually it can be affected because of petrositis or any conditions in the subarachnoid space. Like for example, when there is a raised intracranial tension, there can be stretching of the sixth cranial nerve on both sides, leading to bilateral sixth nerve palsy. And this is known as false localizing sign because the lesion is not at the level of this subarachnoid, but the tumor can be somewhere else, which is giving rise to a raised intracranial tension. So you get this bilateral sixth nerve palsy also in meningitis, subarachnoid hemorrhage, or when there is petrositis in middle ear infection. There can be simultaneous involvement of the trigeminal nerve, sixth nerve, facial nerve, and the patient may be having hearing loss. And this combination is known as Grada-Negos syndrome. And you can also have a basal skull fracture or a CP angle tumor. For example, in this radiological image, you can see there is a tumor in the cerebellopontine region, which is giving rise to a sixth cranial nerve palsy. So after passing through the Dorellos canal, it enters the intracavernous region, and here it lies in close proximity with the third cranial nerve, as you can see here in the picture, the fourth cranial nerve, as well as the first division of the fifth cranial nerve, which is the ophthalmic division of the trigeminal nerve. So you can see the sixth nerve lies in close proximity to these three nerves here. And the important thing is the sixth cranial nerve runs through the middle of the cavernous sinus, as you can see here, whereas the other third, fourth, and fifth cranial nerves, they lie in the lateral wall of the cavernous sinus. So the sixth nerve is the first nerve to be involved in any cavernous sinus pathologies. And this is usually accompanied by a postganglionic Horner syndrome because the sympathetic plexus, which is around the carotid artery, actually is also in close proximity to the sixth cranial nerve. And this is known as the Parkinson's sign. So the various cavernous sinus lesions that can give rise to sixth nerve palsy are carotid artery aneurysms, caroticocavernous fistulas, then tumors like the cavernous hemangioma or Tolosa-Hunt syndrome, which is a granulomatous inflammation of the cavernous sinus. So in the picture below, you can see the patient has a right sixth cranial nerve palsy leading to an abduction deficit with mild ptosis and also meiosis because of the coexisting Horner's syndrome. And this patient actually had an intracavernous carotid artery aneurysm, which was compressing the sixth nerve in its intracavernous segment. So from the intracavernous part, the sixth cranial nerve, it passes through the superior orbital fissure and passes through the annulus of Zinn to enter the orbit, where it innervates the lateral rectus on its inner surface. And here it has a short course, and certain causes which can affect the nerve or the muscle give rise to lateral rectus paralysis in the intraorbital part. So based on the different segments of the sixth cranial nerve, starting from the nucleus in the pons, followed by the fasciculus, the basilar part, the intracavernous part, and the intraorbital part, the etiologies can be various, and also the clinical features will depend on the level of the lesion, and this can guide the clinician to the level of the lesion and then plan further investigations and management of the patient. So a child presenting with sixth nerve palsy can have a congenital sixth nerve palsy, which can be either due to post-viral or vaccination or birth trauma, or it could be a part of a congenital anomaly like the Mobius syndrome, or certain important acquired causes in children can be due to raised intracranial tension, trauma, infections, or tumors like the pontine glioma or metastatic neuroblastoma. Painful sixth nerve palsy can be due to ischemia following a microvascular abnormalities like diabetes, hypertension, or atherosclerotic occlusion of the vasa nervorum, or inflammatory causes like I had mentioned the Tolosa-Hunt syndrome, or aneurysm or metastasis in the cavernous sinus segment, or ophthalmoplegic migraine. Certain mimickers of sixth nerve palsy are also termed as pseudo sixth nerve palsy, especially when it is bilateral. So you have to rule out myasthenia gravis, thyroid ophthalmopathy, medial wall fracture with medial rectus entrapment can also lead to an abduction deficit, and congenital conditions like Duane syndrome, Mobius syndrome, or infantile esotropia, or sometimes it could be just a convergent spasm or a divergent paresis, which can mimic a bilateral sixth nerve palsy. So when you work up these patients, you need to check certain things in the eye, which include the extraocular movements and also the coexisting involvement of the third and fourth cranial nerve can give a clue as to a cavernous sinus lesion. And if the patient has a horizontal gaze palsy and has difficulty in initiating a gaze towards one side, then there could be a PPRF involvement. And nystagmus is commonly seen in tumors like pontine glioma and CP angle tumor. And also look for anisocoria and mild ptosis, which could indicate a Horner syndrome, and check the fundus for papilledema, which will help in identifying a raised intracranial tension. So we also need to do the diplopia and Hess charting to identify the diplopia, as well as serial follow-up of the patient will help us to know whether the condition is improving, worsening, or is remaining same. And we can do a force duction and a force generation test to know whether it is a paralysis or there is some other restrictive pathology. And also we will know the strength of the lateral rectus muscle when we do the force generation test. So the systemic workup will include examination of other neurological signs and carefully look for any hemiparesis and involvement of other cranial nerves like the trigeminal, facial, or the eighth cranial nerve, and also look for any cerebellar signs like ataxia or intention tremors, which can indicate a CP angle tumor. Then check for a middle ear infection or the otitis media to rule out Gradenigo syndrome. Then look for a battle sign, which is actually an ecchymosis over the mastoid area, which can actually indicate a petrous bone fracture, which may be uh, having a sixth nerve palsy. And also in certain conditions where you're not able to identify any ocular pathology, it's better to get an ENT evaluation to rule out a nasopharyngeal carcinoma. So the other investigations will depend on identifying the cause. For example, if you have an elderly patient with comorbidities like diabetes or hypertension, we need to check the blood pressure and blood glucose levels. If it's a middle-aged patient and you're suspecting an inflammatory etiology like the giant cell arteritis or any other vasculitis or autoimmune condition, it's better to do an ESR and CRP or FTA ABS to rule out a syphilis. Then you can, if you're suspecting thyroid ophthalmopathy or myasthenia gravis as a mimicker, then it's better to do tests to identify these conditions. And lumbar puncture can be done for CSF analysis to rule out meningitis. And finally, the CT or MRI scan of the brain to pick up intracranial lesions like tumors or hydrocephalus, and cerebral angiography when you're suspecting a aneurysm compressing the sixth cranial nerve. So a summary of 6 retrospective studies on patients with sixth nerve paresis has shown that around 30% can be attributed to miscellaneous conditions like leukemia, migraine, pseudotumor cerebri, or benign intracranial hypertension or multiple sclerosis, rather than actual intracranial space occupying lesions, which can give rise to sixth nerve palsy. And another 30% can actually be of undetermined etiology, which are actually transient, benign, and unrecognizable or idiopathic sixth cranial nerve palsy. So, is it necessary to do an MRI brain in all cases? So, the answer is MRI should be indicated when the patient is young, less than 45 years of age, because it is more likely to be due to an identifiable lesion in the brain. And also, if it is a painful sixth nerve palsy or associated with other neurological abnormalities like hemiparesis or cerebellar signs, or if the patient has a history of cancer, then we need to rule out metastasis. And if it is a bilateral sixth nerve palsy, we need to rule out a raised intracranial hypertension, which may also have papilledema. And also, if the sixth nerve palsy is progressing and there is no improvement, or it is a recurrent sixth nerve palsy, we need to do a MRI brain. So with this, I conclude my lecture, and I hope the learning objectives are fulfilled, and I thank you for your patient listening.